happy to see, your career thrive as you so well deserve. And I'm very happy to be here today. And I understand a mostly Brazilian audience. I'm really very fond of Brazil. I've been there to the Jornada Paulista once. And I would like to remember a good friend of mine, which unfortunately passed away, another observer, Mirella Maccarini Perucchi, who passed away a few years ago. Maybe some of you will remember her. She was a great lady and a great friend for me. So I'm really happy to be here today. The topic that we chose together, really, errors in neuroradiology, I think is really relevant. What I was looking at very recently in my unit was a worrisome increase in the number of errors that I was understanding that we were making. Okay, so I tried to look and I tried to research the topic a little bit to see what can be done in order to improve the quality of our activity, understanding that, of course, making mistake is entirely human and it's not totally avoidable, but of course we should strive to reduce as much as possible the degree of mistakes that we make in our practice. So this basically started as a journal club, and I was actually looking at a number of articles that deal specifically with the topic of errors in the field of radiology. I found these two papers that I would like to acknowledge from the beginning, because most of the concepts that you will hear today stem from these two articles. There are other contributions out there in the literature, but these two struck me a lot, and I tried to see how I could follow the reasonings of these authors and adapt it to what I saw happening in my own unit. So most of the cases that you will see today actually are my own mistakes. I have no problem acknowledging them. Some are my colleagues, or some others are errors that I saw happen from outside consultations. So the background is that the rate of missed, incorrect, or delayed diagnosis in medical practice is quite high. Looks as if it is between 10 and 15%, which is not entirely a negligible number. And of course, part of this diagnostic unreliability is related to our errors as radiologists. And of course, as our involvement increases with the booming number of radiological studies that are requested, oftentimes at the very beginning of the management of any given patient, when little is known about the clinical history, of course, we are at the forefront. Now, as we look at the moment, the number of radiological imaging worldwide is estimated at 4 billion per year. And this is steadily increasing. So even by taking a very conservative approach and estimating that the average error rate in the reading of this imaging is 4%, which many authors believe to be a low figure, still there would be 40 million radiologists error per year. So if you're thinking about a mistake that you may have made and you worry about that, you are in good company. There's a lot of mistakes, lots of errors, lots of inconsistencies in our work. Now, of course, the radiological work is quite variable. We try and we strive to work along recommendations and guidelines, but there's a lot of variability and a lot of extreme cases, okay? So this variability transpires in a number of inconsistencies in our practice. What you see here is a very important paper, and these guys looked at discrepancy rates among experienced radiologists in a field that is not neuro, abdominal and pelvic CT. However, what basically these authors were asked to do was to reinterpret 30 of their previous interpretations and 30 of outside studies. And what resulted was a 26% inter-observer discrepancy and quite scary 32% of intra-observer discrepancy, meaning that these experienced people did not agree with themselves in retrospect. So that's just to give you an idea of what the problem we are facing. The first guy who really looked systematically at the issue of errors in radiology was this gentleman that you see here, Dr. Leo Garland. Of course, at that time, he was basically looking at X-rays, chest X-rays, but still recognized that important findings were not noted in as many as 30% of chest radiographs that were positive for disease. And also the false positive rate was not negligible, about 2% for negative cases. So the problem of error is big and looming in our everyday practice. But what kind of errors do we make? Basically, two categories of error are recognized: perceptual and cognitive errors. So what is a perceptual error? A perceptual error occurs when an abnormality was not recognized by the radiologist at the time of the primary interpretation, but is then subsequently found to be present. Whereas cognitive errors are errors of interpretation. So we do notice the presence of an abnormality, but we fail to recognize it as such, or we fail to attach the correct importance to this abnormality. So these are the two basic categories, and quite expectedly, the perceptual errors are about 60 to 80% of all errors, which is quite scary because in these cases, we fail to recognize the presence of an abnormality in the imaging studies. What are the risk factors? Concerning perceptual errors, the main risk factors are a poor conspicuity of the lesion. So the lesion is perhaps small or not well contrasted with the remaining the remainder of the image, so it's not easy to see. But sometimes reader fatigue, an overly rapid pace of performing interpretation. So when we sit in the reading rooms with hundreds of cases and we go fast, distractions. So phone calls, emails, social media, another colleague that enters the room, coffee breaks, whatever, that distracts us and interrupts us. The big elephant in the room is so-called satisfaction of search. Means that we do see one abnormality on an image, but we fail to keep searching for a second and a third. So we stopped at the first thing that we see, and we don't go on looking for more abnormalities. And unfortunately, like in anything in medicine, there's also an idiopathic category here. These are the perceptual error risk factors. What about cognitive errors? Well, the risk factor, the biggest one, of course, is lack of knowledge. That's when we go out there and we start reading cases without really knowing what we're doing, without having a steady and steadfast preparation in what we need to do. But then there are cognitive biases, and we will take a look at what I mean later during this presentation. Misleading clinical information, and that's very common in my country, I should say, perhaps also in your country or elsewhere, is when basically the clinicians don't tell us exactly what the patient has and what we are supposed to look for. Also, the radiologist inadvertently propagating an error that was previously made by another colleague. So we stick to the previous interpretation that was made without challenging it. So these are the two errors. And another problem is that radiologists seem to be quite prone to repeating the errors. So there are errors that accumulate and create a sort of big mountain on top of which we need to stand. Now, in this very interesting article, 12 different categories of errors were identified. I found it very enlightening. So I decided to go through these various types of errors, adapting them to my reality. I'm a pediatric neuroradiologist. I work in a tertiary care pediatric center, so I don't see any adults except for fetal MRs, and I don't see any body radiology, but you could easily adapt the same categories and perhaps, as I mentioned them one by one, something that you have seen or some skeleton in the closet, put it this way, will come up to your mind. So let's start with the first one. And the first, before doing that, let me just show you that the largest risk category among radiology examinations, of course, radiography. Think about mammography, for instance, but also chest X-rays, because of course, there's so many of them. So it's quite logical that a large number of errors sits there. But about 40, more than 40% of errors lie in those imaging methods that we are supposedly more familiar with. And actually, this paper was written 9 years ago. And certainly in this past 10 years, the number of CTs and especially MR scans that are performed has greatly increased. So I expect that if we were to look at these figures today, we'd see a larger number of errors exactly in the categories of examinations that we perform on the everyday clinical basis. So let's start from the first error. The first error is an error of complacency. So that's a true, it's a false positive error. Basically, we misinterpret the images. We appreciate something is wrong, but this is unimportant. This is an unimportant finding to which we attach too much importance. So basically, by doing that, we artificially transform a healthy individual into a patient. This was a case that was important in my case. I see Cesar in the background nodding, so perhaps you will remember, Cesar, what I'm talking about. This was actually a case where this 2 years old came for occipital headache, and I found, and you know, it's like when you see an image and you don't know what to do with it, but you can't simply take your eyes off it. So it's there and you don't know what to do, and so you start making a differential diagnosis of perhaps what could it be, what it could not be. And of course, this was a patient at 2 years. Now you see the follow-up at 7 years, the lesion has basically gone away, expectedly so, I should say, in retrospect. But of course, what I did was ruining the infancy of this child, at least of the parents, because I implanted in their heads the thought that this could be perhaps a tumor. And so the patient underwent several follow-ups and eventually the lesion disappeared. And now we know this is the torcular pseudomass, which is basically a transient maturational feature of the connective tissue in the dura and around the skull. But we didn't know that. So we overstated the importance of this kind of lesion. A second error is more, and you can see the numbers out there in red, are the percentages based on the article and based on the author's find. You may decide whether these percentages are the same in your clinical practice, okay? And certainly an error of faulty reasoning is probably very important, 9%, perhaps more. It's another false positive error, but in this case, what you have is not that you do not appreciate, or that you appreciate a lesion which is actually not a lesion. You see the lesion, you interpret it as abnormal, but you attach it to the wrong cause. And this is a case that I've been showing at each and every workshop that I did, perhaps, because it's so scary. This was a lesion. You can see this large lesion. There's an abnormal vertebra, but of course, a large intercannular lesion. And at that time, it's many years ago, what I saw and what I appreciated and what I wrote in my report was that this was probably a hemorrhagic tumor based on signal intensities. What I failed to recognize were these flow voids and these pulsatility artifacts. So this was not simply a hemorrhagic tumor. It was, in fact, an osteoblastoma associated with an aneurysmal bone system. You can see the extensive vascularity of the lesion. Now, this angiography was performed after the patient almost died in the surgical theater, because the surgeons went in, they tried to operate, and they had profuse bleeding. And this was due to the fact that I failed to recognize that this was not just a tumor or a hemorrhagic tumor. This was a vascular tumor, okay? So they went in and almost killed the patient. And that would have been my fault, okay? So I'm very happy to know that this is a patient who's alive and kicking right now after many years. But this, I will never forget this case. And this was a case of faulty reasoning on my side, coupled on the fact that, of course, as you may imagine, when you have such an emergent case, the MRI is flooded with surgeons, neurosurgeons, oncologists, and whatnot. And this creates a chaos that is difficult to control. Another very recent case of faulty reasoning. This is a meningioma. Perhaps for everybody is very easy, but for me, I thought this was an intraaxial tumor. I was not able to really recognize that this was, as it is, and as it was proven, an extra-axial tumor. I couldn't see the convolution pushed away by the lesion. It looked like a cortical mass. Well, we could discuss forever, but this is an error. This is an extra and not an interaxial tumor. This is another lesion which really, I'm really, you know, sometimes I think I should perhaps go to the seaside, you know, rather than being a doctor, and perhaps open a bar in some beautiful beach in the northeast part of Brazil. I mean, you know, I sent this patient to the surgical room with, this was a single lesion, by the way, with a diagnosis of tumor of unknown origin. This was a single demyelinating plaque. This is demyelination. It doesn't have the open ring, okay? It doesn't have the typical aspects. The color image is APT, and APT is said to have increased signal in case of a high-grade tumor. This is another error of faulty reasoning, ending up with a limited amount of differential diagnosis. If you limit your differential diagnosis too much, if you go too straight to one conclusion, you risk interfering with the management. This patient could have been treated with steroids, and he went to the surgical room and they took this lesion away. Lack of knowledge is another big beast, of course. And we all, you know, especially now that everybody understands that almost everything has been published. If you start searching, you find many, many articles with many information, okay? So it's really difficult to claim lack of knowledge, but this is a case. And I do remember this because this was solved by a first-year resident while we were talking about this case for many years without coming out of this kind of lesion. You can see these bright lesions in the cerebellum and in the temporal horn in the patient who was here for epilepsy, and nobody knew what it was, what it is, what is not. And then my younger colleague, Dr. Severino, immediately as she saw the patient, she said, "This is neurocutaneous melanosis." And we said, come on, the patient doesn't have any nevus and no cutaneous birthmarks. And she said, why don't you start looking very seriously? We asked the mother, and here it was, it's just below the skull, a very large melanotic patch. So, you know, another error, basically lack of knowledge. We didn't know what it was. We didn't think sufficiently. I was not aware of neurocutaneous melanosis at the time. I had not seen a case. So another error. And I think that lack of knowledge is very important. I'm not sure it's 3%. I would say more than 3%. But again, each of these categories looks to me larger than the number that is written there. But then eventually the sum must be 100%. Okay, so we can decide if it's 3 or 6 or 10%, but not everything can be 50%. Otherwise, it would be mathematics would be wrong. Okay, so another case of lack of knowledge. This is when you fail to realize that there is a lesion. This is actually a relatively common error when people are not familiar with the normal appearance of lesions and there is no obvious asymmetry or there is no obvious lesion. So you get a perceived normality. And this was a patient with septic shock, multiple cardiorespiratory arrests, and a radiologist was reading it as normal. Of course, this is not normal. This is a very severe and diffuse cytotoxic edema that involves the whole of the brain. So this is as abnormal as can be, but because there is no obvious asymmetry and because the person that is reading is not really familiar with DWR, the brain, the case risked to be read as normal, which of course it was not. Okay, so let's see a few practical tips about how to avoid these first 3 categories of diseases. Well, you need to maintain current knowledge through the literature. So you need to study. That's the whole thing. You never stop studying. You go there every day and try to learn something new, and perhaps attend courses. It's a good opportunity to invite everybody in Brazil to come to the ESNR annual meeting in Lisbon, Portugal in September, where you'll have beautiful courses and possibilities to learn. But there's so many activities out there, it's almost impossible not to obtain high level knowledge. But also it's very important to analyze critically the mistakes that we make in the department, to issue and to perform monthly revisions of our errors, which are not meant to blame anybody. It's extremely important to instill a blame-free culture in our department. It's not that the one who makes less mistakes is just, you know, a superhero and the other are stupid people. No, we all must learn from our mistakes, and by sharing our mistakes, And by allowing even the younger colleagues to speak up, we can reach a better level, and we can certainly increase the likelihood of having correct performances. A fourth important, and in this category, probably the largest one, is an under-reading mistake. And simply, the lesion is there and it is missed. And this can have catastrophic consequences. This is a case, came from an outside institution for headaches, read as negative. There's a large pineal cyst, which was, of course, reported like all pineal cysts. Obviously, the pineal cyst is not the main culprit. This is the problem. And here is the follow-up after 2 years with a very diffuse ependymoma that, of course, has grown from those initial nodules and now has become incontrollable. So this is a problem of under-reading. And I believe that there are so many of these problems that it's a little point, there's no point in showing many others. We know that under-reading is the main problem. How can we avoid it? Well, we must learn to systematically approach the search of diagnostic images, adopt strategies, including checklists, structured or semi-structured reports that will help us avoid the problem of under-reading. Also, redundancy networks, safety nets like second reads. We read the 10%, we second read the 10% at the moment of our examination. So there's a second reader that takes 10% of our in-house examinations and re-reports them or checks them, okay? So you can do it, and this will increase the likelihood if there's any problem. You cannot do it for each and every exam, okay? But you could set for yourself a goal, 7, 10, 12, 15% of the examinations in your department could be read by a second reader after the first reader has read them. Also, specifically look at the first and the last image in a series of images, because it looks as if the first and the last usually are the most likely to be overlooked. The scout or localizer images are a very important part, and you should look for them. Look at all corners of an image, and also those areas of the exam that are not really at the forefront. You're doing a head study, but there's something in the neck. You're doing a spine study, but there's something in the chest or the abdomen. These are the kind of things that you need to look. Another major error is failure of communication. I think this is extremely important and not really acceptable in the era of communication like we are doing today. It's when you fail to convey a message. So you identify the lesion, you interpret it correctly, but the message does not reach the clinician. There's many reasons why this does not happen. And I think, I'm sorry to say that the major reason is that often radiologists adopt a defensive policy. So it looks as if we are incapable or we do not dare writing conclusions to our studies. So there are beautiful reports, very detailed, but then there's no conclusion. So the message, which is what is important, does not reach the clinician properly. For instance, this was an ER examination, a patient who had a previous surgery for medulloblastoma. You see all this calcification. This is an obvious case of Gorlin syndrome. The patient has been treated with radiotherapy, comes back in, and what the radiologist in the emergency room writes, you can read it there. But only after 6 days, the patient went on to do an MR, and this was a large meningioma that compresses the brainstem. But failure to correctly convey the message, this left paratruncal hyperdense area warranted further study. It's simply not enough, okay? That's not enough to write this without any kind of conclusion. This was overlooked by the clinician, unfortunately, only after 6 days, but it could have been 6 months, okay, that the patient comes back for an MRI. So practical tips, lack of clarity, try to avoid absent, misleading, or defensive conclusions. I do understand the problem of defensive medicine, of course, but it doesn't mean that we should avoid taking our responsibility and at least offer a range of differential diagnosis, if not a clear-cut diagnosis. Avoid abbreviations that are not understood by other people, avoid jargon, and also language flourishism or mannerisms are usually not seen very well, especially in courts. The judges are not impressed by mannerisms or jargons. Also, use those guidelines that are there in the ACR, the American College of Radiologists. it is clearly written that radiologists should speak directly with the referring physician and document the communication in the radiologist's report in the event of any urgent finding. So it's not simply enough if you have like an uncompensated hydrocephalus that you write the report. You need to call somebody and let them know, hey, this is a patient that needs surgery. And we have it also we call it somehow different in my institution, we call it critical values. But anyway, you need to do it. And then when you do that, it's a problem of the surgeon. Now, for instance, this was a patient, very recent one, with a cranial stenosis. The patient also had a posterior fossa tumor that was eliminated, was taken out. And here in the post-surgical image, I noted an enlargement of the ventricles. You can see the congruent enlargement of the frontal and temporal horns. So I said, this is developing hydrocephalus. And I alerted the clinicians and I wrote it in the report, and I also called them and noticed in my report that I had called the neurosurgeon to alert them to the developing hydrocephalus. Then it is not my fault if they choose not to operate the patient and the patient then comes back in after 5 days and needs emergent surgery. And that's that's another indication of critical values, okay? But as long as I have conveyed the message, it is now in the hands of the neurosurgeons to decide what or what not to do. Technical problems are extremely important. Now, we have plenty of examinations, and sometimes the examinations contain problems because the lesion is there but cannot be seen because the technique is incomplete. Now, for instance, this was a 2-month-old with nystagmus and apnea, and the patient underwent a first MRI in an outside institution where they used an adult protocol. You see 5mm thick slices. And basically, on this kind of quality of images, there's very little to say. Of course, for those of you who are more careful, the shape of the fourth ventricle is a bit funny, but this was reported as normal. Patient came to our institution. We're not just clever. We just did what we normally do, which is a high resolution study. It's a 3D 1mm study. And of course, that's a molar tooth in the context of a Joubert syndrome, which was completely overlooked simply because the technique was not sufficient. But sometimes we know that we need to choose the correct technique. This is a case of encephalitis. You can see the comparison between a normal CT and a very abnormal MRI at the same time. Of course, if you choose CT in the context of an emergent study, I think that you will have very little satisfaction. And that's why we're moving very much towards fast MRI protocols in emergency, just because MRI is so much more sensitive. But then it's not enough sometimes to do MRI, like in this case with migraine with aura, in which the standard MRI is completely normal, whereas ASL clearly shows hypoperfusion of the left hemisphere. So when you start doing MRI, you need to make sure that your protocols are significant and adapted to the clinical reality of the patient that you're looking at. So practical tips will be to try to use standard protocols as much as possible, customize sequences for age, the effect of myelination and how you need to adapt your sequences to the degree of water of the unmyelinated brain. And you need to involve the radiographers, get people to understand why you're doing specific protocols and understand what kind of protocols need to be performed in individual patients. So strive for personalized precision medicine in neuroradiology. Prior examinations, if you fail to look at the priors, then you may miss important findings. And sometimes it's difficult to look at long histories or long lists of prior examinations. But for instance, if you look at this patient had previous surgery for a chiasmatic hypothalamic tumor. The patient got radiation. And if you closely look at these vessels here, the MCA, especially on the left, is very, very small, and there are all these tiny vessels. So this is a case of moya-moya. That's a post-radiation moya-moya in this case. And what was written here in the report, advise a MR follow-up with arterial MRA and perfusion study, because these two studies were not performed in the initial protocol. So the person reporting here advised that at the next examination, these two sequences would better be done. So the patient duly comes back after a few months, and the report is again the same, because again, in this second examination, the MRA and the perfusion have not been made. Why have not they been made? But because the person who was planning this study did not look and did not read the previous report. So he or she didn't know what to do with that. And then, of course, then the patient comes back again after another 2 months, and you can see how severe the picture is. Now, the moya is a progressive kind of disease. You don't want to, miss and waste time, in follow-ups if the situation is as severe as this is, because this is a patient that needs surgery. So retrieve and review all the prior pertinent radiological examinations before rendering final interpretation, and also double check for outside examinations. I don't know what your reality is, but in my reality, quite often, a single patient has multiple anagrammics in the PACS. So it's as if the same patient has different files which are not synchronized with one another. This may mean that you're looking at the priors, but not every prior examination is under that file. There could be another file. If that is the situation, you need to make sure that also other examinations that may not be in the patient file are scrutinized. It's a lot of work. It's good work for the residents, at least. History is extremely important. If you don't know what the patient has, you will make mistakes. This is a case that I will always remember because I read it negative. So the patient had seizures, okay? So I reported this patient negative. Of course, you have seen the lesion already, but these are selected images, of course, okay? So I didn't know anything except for seizures. So the patient, I go to one of those, grand rounds, epilepsy grand rounds with neurologists, neurosurgeons and whatnot. They show this case, and immediately a neurologist, of course, not a radiologist, a neurologist points at the finger at the image and says, hey, but that's a clear-cut focal dysplasia of the cortex. Of course, it's right there. You can see this tiny stripe here. But what I was missing was knowledge of the clinical information, which was already available at the time of the initial imaging, but I didn't know about that. There was a left frontal EEG focus, okay? So that is one good reason why I stopped attending those grand rounds for quite some time, because I was totally ashamed of myself. But unfortunately, that was my fault. So history, knowing the clinical history is crucial. So you need to research it. You need to read the charts, the clinical summaries, at least the discharge letters, okay? Remember that often important clinical tips are found in the prior radiological reports. I don't know how you report, but normally we have a structured scheme. We have indications, technique, results, conclusions. So indications will read what the patient has. So if you don't exactly know what the patient has, maybe reading the previous report, you will have some information in the indications. But try to get the clinical information, because unfortunately, when you read the request coming from the clinicians, it is often scant, wrong. They will ask for checkup or follow-up, something like that. But the relevant issue, the relevant question may not be present in the request for the imaging study that you're performing. So you need to know exactly what you're looking at and why you're looking at it. Location is extremely important. You miss the finding because you're not looking in the right direction. So you're looking at the center of the image, but the lesion is elsewhere. For instance, in this case of a hydromyelia. So you're looking at the brain and you're not looking at the cervical spine, but there's a hydromyelia there, whatever the meaning it is. So look at the corners of the image, all corners of the image. Adopt a cognitive strategy to look at images. Again, try to perhaps spend some time in researching how you look at the studies, how you look at the images. It's important because each and every MRI study has 3,000, 4,000 images. How many images do we have? So it's really difficult to look at them all. And I acknowledge that I do not look at all the images that I acquired. And I'll bet you also do not look at all the images that are acquired. But so how do we choose the images? Why do we choose to look at some images rather than others? And that's cognitive, and we can research and maybe try to find some improvements in that. I try to look around. I try to scroll repeatedly. I try to use windowing, use the mouse to change the window a little bit to try to find out. I certainly do not, if I'm looking at a series, I just scroll once or twice or even thrice to look repeatedly at the images that I'm passing through. Satisfaction of search, that's a big enemy. The finding is there and it's very relevant, but you are failing to search for it. So there is one obvious abnormality that you're looking at, but there's a second one, and you stopped looking for the second one. So for instance, this was an absolutely scary case because you see a patient who's undergone meningioma surgery. Okay, so what is left here? It's after 2 surgeries. There's still a meningioma. You can see the lesion there. I'll bet you that you're basically looking at the post-contrast images in these cases, and you just make the comparison with the previous examination. So you're looking at the post-contrast images. But what is this thing? Well, if you fail to notice that this is in fact a pseudo-aneurysm of the basilar artery secondary to the surgery, and you fail to recognize this, the patient will die. I'll tell you that when the patient got to the angiography bed 2 days later, the size of the aneurysm had doubled. Okay, so this is what kills us really and may kill the patient: satisfaction of search. We see one thing that is quite obvious usually, and we fail to see the second one. So we need to overcome the urge to stop looking after initial finding is detected. And of course, if we have a very rapid pace of reporting, that's a major critical issue, because of course we need to, you know, press on and report and report and report and report, but we stop looking. So we need to continue to try to evaluate the radiological examination. Of course, if we use checklists or structured reports, that will be extremely useful to, you know, avoid stop looking. Complications. What are complications of a procedure? It's not just a complication like from surgery, but a complication in our report. For instance, this is a lesion involving the left temporal uncus in the report. Of course, it's not the left temporal uncus, it's the right one. That's a very common and avoidable mistake. This is a post-contrast T1 according to both the radiographer and the nurse that injected the contrast. Of course, that's not the post-contrast T1. That's a T1, and they injected the contrast, and the contrast went, I don't know where, probably in the subcutaneous tissue of the arm. So that's what they sell you as a post-contrast T1. It's not the post-contrast T1. But the most scary one is when you fail to correctly identify the patient. So you have, and it happens once in a while, I'll tell you, it happens. They start the examination and the name of the patient is somebody else. That's extremely scary. That's one of the most scary things that you can do when you start performing an examination and it's not the patient that you're thinking he or she is. So you need to adopt timeout strategies, which are time consuming and sometimes look a little bit stupid when you ask, what is the name of the patient? Have you checked the bracelet, you know, or any form of identification? You need to involve the radiographers and the nurses, because normally you are in the reading room, so you know nothing about the patient, but you are ultimately responsible. And finally, satisfaction of report. And that's when you do not dare to challenge yourself or your colleagues. Okay, so you miss a finding because of complacency, so you overly rely on the previous radiology reports. So this, for instance, as you can see, is an obviously changed lesion. This is a multinodular vacuolar tumor. That's a new entity that we are now very familiar with. It's obviously increased, but there are 6 unchanged reports. Unchanged, 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 okay? And so you're not looking at, you know, back enough. You're just relying, it's unchanged with the previous exam. That's a big mistake. Here's another one. This was reported as a disc herniation in 2013. Now in 2021, it is unchanged. It's obviously not unchanged, as you can see. It's not even a disc herniation. It's an exostosis, okay? But nobody challenged it. Now, this is a patient who could end up with a spinal cord compression. So it's not exactly something that you want to, you know, to just not consider. So practical tips, basically perform your own interpretation before reading the previous radiology reports. That's how you can form your idea without a bias from previous reports. So we're talking about biases. Let me show you what kind of biases, cognitive biases we have in radiology. I think it's important. The first one is called, there are 5 biases basically. The first one is the anchoring bias. So basically we lock onto a salient feature too early in the diagnostic process. So we're just look at the first thing that we see and we get enamored of it, we love it, we have our impression, and nothing is going to shake us from that initial impression. despite new information or conflicting information that may appear in subsequent times. So we need to make sure that we still remain skeptic and we do not fall in love with our own reasoning too much. A second one is the so-called availability bias. It's a recent experience with a disease will probably make it more likely that you tend to see the same disease again, okay? And tend to make the same diagnosis again. And conversely, if you haven't seen a disease for a long time, then you may fail to recognize it, despite the fact that you know about that disease, but perhaps you haven't seen it for a long time and you forgot it. And there's a beautiful example of this one. I'll show you this case because it's really very nice. As a patient comes in with an obvious spondylodiscitis, okay? But the patient also has enhancement of the thecal nerve roots. And that's something that is not really so easy to think about when you have spondylodiscitis. That's a different spinal compartment. So do not expect to have it enhancement of the nerve roots. But anyway, we don't know what it is. The brain MR is normal at that time. Patient is treated for spondylodiscitis and spondylodiscitis goes better, but then the patient suddenly gets worse after 8 months, new neurology. Here's the follow-up after 8 months. And you can see that the spondylodiscitis is really doing very well, but the enhancement of the nerve roots is still there. It's even more than before. And now the brain MRI is no longer negative. Of course, that's the tiger pattern of metachromatic leukodystrophy. And I was not able to make this diagnosis in 2019. I didn't even think about metachromatic leukodystrophy as a differential diagnosis in this case. Of course, in 2020, it was easy. But of course, it was reported. It has been reported. And it's there in the literature. You can see that enhancement of the coda equina can actually be simultaneous or even precede the typical leukodystrophy. And that's typical of metachromatic leukodystrophy and Krabbe disease. So it's not just that the information is there. The problem is that I was the author of that paper. So actually, but it's in 2009. In the meanwhile, I have forgotten. Of course I know, but it's not in my mind. So it's a problem of availability. I'm just looking at a very small amount of the possible landscape, okay? And the rest of the information, which is somewhere in my mind already, is not available to me. And so that's a cognitive bias. Another bias is confirmation biopsy. So we tend to look for the confirmation evidence of our initial hypothesis. So if we have other information that refutes our hypothesis, we tend to discard it and to overlook it. And that's another of those biases that probably we can recognize that we are doing. Another one is the outcome bias, especially in the pediatric world, it's quite common. We tend to favor those diagnoses that have a better outcome because we are on the same side of the patient. So we tend sometimes, that's a cognitive problem, to discard the idea of a very severe diagnosis and tend to underestimate, because I've seen it happen with brainstem gliomas, for instance. People refuse to diagnose a brainstem DIPG, okay, because of the dismal prognosis that it has. Final one is the so-called zebra retreat. It's very important. The zebra is a rare diagnosis, okay? So the diagnosis is supported by the history, by the imaging findings, but you do not dare make it because you do not dare to make a fool of yourself. So you don't want to report. And I have a very recent case. I knew this was a giant cell tumor. That was crazy because when I wrote the differential diagnosis, I didn't include it because I thought it was too crazy to be, because it's in the sphenoid bone. The sphenoid bone, I didn't want to, and I knew they would get a biopsy. So I didn't write it. And then when they came out, I said, Mike, I had it. And I just was a bit shy. And if I can be shy after 30 years in the practice, in the business, you know, everything can happen. So what are eventually the strategies? Let's recap a little bit to reduce the errors that we do. We need to be vigilant, to be in constant doubt, which doesn't mean that we do not take an eventual position, of course, but let's not get too enamored of a favor diagnosis too early in the process. And pitfalls that we have discussed today, I hope it was useful, you know, to sort of pinpoint our attention in what we do on an everyday basis in order to get rid of these biases. Sometimes there are even cognitive debiasing approaches. There's even psychologists, if you will, that they help you. I'm not really too fond of psychologists meddling with our work, but there is interesting research that has been made in cognitive debiasing. Always strive to have a sufficiently broad range of differential diagnosis, especially when you're formulating a conclusion about unknown cases, okay? So if you don't know what it is, try to think about alternatives. If you just go straight for one thing, it could be a mistake. Let's try to reduce the variation or the variability in the practice at all levels. You know, try to be consistent, use protocols, use checklists, try to learn and keep learning. There's nobody who's a master. You know, sometimes I think I'm ready to retire because every day there's so much that I realize I do not know. And it's just, I don't want to belittle myself in front of an audience. It's the truth. I mean, you have the case that you don't know anything about, okay? And you got somebody coming to you, up to you, sometimes if you're in a chief position, asking, you know, for the word, you know, but there's no, sometimes you need to be able to say, I don't know what it is. So use checklists, use structure and semi-structured reporting strategies, effective technological aids where applicable can be useful to reduce the mistakes. There comes a time with assisted diagnosis. It's looming in there in the future. It will be in your, and perhaps even in my, career landscape and my horizon. So there will be a time when computers will assist us. Concentrate and spend time on a clear, effective communication. You need to convey the message. And the message must be there in writing, because then when the judge calls you, they will look at your written report. So even writing that you have made the phone communication with that doctor at that time about this diagnosis can be very important and can save you from complications. Use all sorts of harm mitigations, fail-safe strategies, safety nets. Second reporting, for instance, can be effective, and you could consider adopting it in your department. Reduction to the extent possible of interruptions and distractions. So the reading room is sacred space, okay? It's not like the neurosurgeon can enter the reading room and start discussing the case with you. Try to go to the surgical theater when they're operating and start discussing another case. You'll be kicked out, okay, and punched in the face. So you should not let them do that. And unfortunately, there is still some, you know, how to say that? It's like we radiologists would be second level doctors, okay? They're the surgeons and we're the radiologists. We are not at their service. We are around the patient bed or virtual bed, but we need to be respected. And I think that we need to reinforce respect of our work environment. And then also becoming attention to individual physician factors, illness, of course, advancing age in my case, I need to be aware of my own advancing age, but certainly, you know, help those who are in need and try to help your colleagues. And start thinking about systems level. So the radiologist is usually or can be a loner. You are in your cocoon, in your reading room, you're there, you're just you and maybe a silent fellow sitting or next to you, and you're there like a monad. You're alone. You're not alone. You are in a system. You are in a grid. You are in a web. You know, connected. So try to connect and exchange information with your colleagues, especially, you know, when you have meetings about cases. I strongly encourage doing meetings about mistakes that have been made in the department to understand what went wrong. And certainly instill a blame-free and just culture so that everybody can contribute to his or her best. And with that, I think, Pablo, Cesar, I think that is all for me for this time. And I hope it was good enough for your expectations. And of course, if there's any questions, I'm more than happy to try to answer them.
Thank you, Dr. Andrea Rossi. It was a fantastic lecture, as always, several important messages to all of us. And I believe we as pediatric neurologists, we still have some privilege of having more control about our patients' protocols. I don't know if I think it's the same for all pediatric hospitals. We have more clinical information about our children than normally in adult hospitals, general hospitals. And also I can imagine how hard it's for teleradiology, how complicated the scenario can be, since at least in Brazil, it's very difficult to have, we have very limited information about these patients and also how to improve the protocols. And it starts to be very hard to go further in our reports and conclusions. And I think that's another point is to, at least for me, it's very hard to define how further I can go in the differential diagnosis when I'm not sure about it. So how long I can go in my conclusion in the sense of, I feel that I'm helping somehow the clinician or someone that's reading my report, and like, how can I jeopardize my report in giving so many differentials that actually starts to give so many complicated differentials for those that are reading it, and cause a lot of trouble for the patient treatment or how they will approach the patient, the care. So these are my considerations. I don't know if you want to discuss something about it.
Sure. Of course, Cesar, you're absolutely right. And certainly teleradiology, I totally concur, is one of those business where the safety nets are simply not there because you know nothing about the patient is not there, you cannot look at the patient, you cannot call anybody, you have only that very limited information that is provided to you, which is often quite scant. So I have no answer for that. You know, there's no answer because the contracts regarding teleradiology and their engagement rules are really depending on the contacts that have been made between the institutions, and you're basically out there in the field and you don't know where the enemy is and you're just shooting in the dark. So it's one big problem, and those with who perform teleradiology must be super humble, you know, try to be to be very careful and not jump to conclusions. You also realize that, as you correctly said, somebody else is performing the examination, maybe, you know, in another country with a totally unexpected protocols and maybe low quality of the images. So it's one issue. I suppose that there will also be, sometimes it will have to transpire in the insurance policies, what we do, because I'm not aware, I don't know if in Brazil or perhaps in the US, you have a different insurance policy as a doctor if you perform teleradiology or not. In Italy, it is not the case. So it is not differentiated whether you do teleradiology or not, but I suspect that somebody will have to look into that because it's a little bit scary, you know, to think of the consequences. Regarding your other point, if I understood correctly, the breadth of the differential diagnosis, well, I'm not saying, you know, I'm not claiming that you always need to write in all the possible diagnoses that are found in Jim Barkovich's book in your conclusions, because that's not your job. The job is to draw conclusions. And sometimes you have cases in which the conclusion is clear-cut, and you can make that conclusion, you can go for it. What I'm saying is that when you have an unknown case, a case that gives you a hard time and you know what to do with that, and you need to write in a conclusion, then you need to include the possible differential diagnosis and spend a little bit of time, because if you go too directly to one thing, then you risk to really leave all the rest out of the scope. So it's a matter of understanding how difficult the case is and how clear-cut you can be. Sometimes I encourage my own people to write that we don't know what it is. I remember my own boss, he always told me, Andrea, but you cannot claim that you will know everything all the time. It's not that, you know, sometimes you need to be able to write in a, you know, acceptable manner that you don't know what it is. You can say, you know, these findings are uncertain significance and I advise follow up, or it could be this and this and that. You need to have the courage to do that. I mean, if you don't want to write conclusions, then this is not the right job for you. That's what I always say to the younger people, you know. But in the business of medicine, you know, it's not, you know, you need to try to direct the further management of the patient, and sometimes you know what it is, sometimes you don't know. So yeah, it is acceptable sometimes to have large scopes of differential diagnosis.
Great. Thanks so much. If you don't mind, there is also some questions here. We have one question from Sarah. She's asking, how do you proceed with the second readings or second opinions from your colleagues? Do you write it in the reports with whom you discuss the case? do you ask them to give their opinion before you tell them yours? How do you?
Okay, so yes, so normally this is a process that is performed after the report has already been finalized. Okay, so there is a report that has been signed and validated by the reporting radiologist, but we go there, and in a matter of like the next 24 or 48 hours, we go in there. We have a feature in our RESPAC system that allows us for, you know, second reporting, and we can write addenda or, you know, other interpretations, and then we'll go in the file of the patients. But it's not like, of course, you can do it the other way around. So the best way would be if there is any uncertain case, you don't know what it is, or you need a second opinion, you go ask your, you know, your colleague or your ask for advice. You know, you can always do that before finalizing the report. I'm talking about something different. So I'm talking about finalized reports. So this is final, and the reporting radiologist doesn't know anything about it. It's over already. But I go there and I second report them. I have a feature in the packs, and I can write addenda. Okay, and this addendum can be like an acknowledgement, like, you know, checking it as okay, or I can write an addendum and say, okay, I also have this additional interpretation or this additional finding, and it will go in the file of the patient. This is very important. It's actually part, the Gaslini is accredited with the Joint Commission International, and it's part of the accreditation to have a certain amount of radiological exams second read, because it's a safety net. So that's the way we do it.
Yeah. I don't know if it's a straightforward answer for this, but second opinions for WhatsApp stuff, like how responsible we are for cases, and when people send us WhatsApp images and asking for opinions. I don't know. I know that's like a very complicated.
But that's the real world, isn't it? It's the real world, because there are entire Telegram channels. I believe that 75% of the people in this room now are members of one or other of those Telegram channels or WhatsApp groups. So that's it. There is a problem, because of course, all of this is not, doesn't meet any kind of standard. You know perfectly well that you're reporting on a pre-selected image on a totally inadequate screen and in inadequate lighting. So whatever you say, of course, you're taking responsibility. I'm a little bit, I mean, I don't want to, look, I mean, sometimes I try to look at those Telegram channels, and it's very interesting. You see strange cases. It's difficult to keep the pace. Sometimes I like to stay a little bit in the background, because I am concerned that you're, you know, like throwing out an interpretation, and turns out that Dr. Rossi in Italy said it was, I don't know what kind of disease. And in fact, you don't have all the information. So it's difficult. It's quite clear, however, that exchanging information about strange cases and, you know, throwing a stone out there, maybe somebody else will have seen the case or a similar case, and you're increasing the likelihood of making a diagnosis, especially in unknown cases. So I do not see WhatsApp as the devil. I do believe that exchanging information is important. I strongly believe that we need to uphold privacy in this conversation. So any kind of identifying information or any kind of relevant information or anything that makes the patient recognizable should be avoided, because you could have legal issues. But I have seen cases, I've had cases myself where I didn't know what it was, and I sent it to colleagues and they got me the diagnosis. So I think you can do it. It should be, I wouldn't say it should be regulated, but we should use our common sense, if nothing else, because there's a risk. There's a risk of missing the diagnosis. There's a risk of, you know, propagating information, you know, especially private information about patients. So it's a risky kind of business. So we always think that nobody will look, that nothing will ever happen. And then we discover once in a while, we wake up and we recognize that there is a cyber war or a cyber attacks. We're hearing terrible things these days on these lines. So we need to be very careful and perhaps not exaggerate. But certainly it's important also to ask second opinions, and maybe the colleague is somewhere else. Or, you know, I want to ask your opinion, and you're in Philadelphia. I need to, you know, how can I easily reach you? I'll send you a WhatsApp image, and then maybe we can exchange the full DICOMs, the full anonymized DICOMs, if the case turns out to be interesting.
So thank you so much, Dr. Andrea Rossi. Amazing. Thank you. I really appreciate all your devices and your knowledge sharing with us. I don't know if Pablo or anyone else from the public want to make any comment or questions.
Amazing, Dr. Rossi. Thank you very much to join us. Fantastic lecture. Good to join us.
Thank you very much.
Thank you too. Have a good week. God save us.
Thank you. Thank you so much. And I really appreciated being part of this thing. And I hope it was useful, and look forward to meeting you all in person once. Okay.
Okay. Thank you, Professor. Thank you, Cesar.
Thank you.
Bye.
Bye.
Bye, everybody. Bye-bye.
Bye-bye. Thank you.